So let's go ahead and take a look at how we go about forming urine through the interaction of the nephron with the surrounding capillaries and arterioles, so as to create either a very concentrated urine or a very dilute urine.
The first thing we have to look at when we look at the regulation of the system is what's actually going to cause the regulation here. And the regulation of the system is based off the plasma volume and the osmolarity, the concentration, more than anything else, in which we're negatively regulated with the plasma volume, in which we're going to attempt to control the amount of sodium that is being excreted and or reabsorbed at the nephrons in order to control the total plasma volume within the blood. While Starling's law will go about controlling the movement of water and the movement of solutions, there are other factors that are going to come into play as it relates to the regulation of filtrate and urine formation. These will include things such as the sympathoadrenal stimulation, antidiuretic hormone, the angiotensin-renin-aldosterone pathway, our concentrations of sodium and potassium within the plasma, as well as our whole body water balance, combined with things that are going to affect our cardiac shift and our cardiac drifts, such as physical activity, and the presence of diuretics within the plasma. Now, while crystallized caffeine, theophylline, and theobromine can have diuretic effects, caffeinated drinks and coffee themselves are not diuretics, as when we actually take into account the volume that is being consumed relative to the volume of urine being produced, there's no more diuretic effect from these beverages than what we see with water. So let's dive a little deeper into this hormonal regulation that we see. So when we look at our hormonal regulation, what we look at is we have an ADH, an angiotensin II, and aldosterone pathways that are all going to attempt to reduce the amount of volume being produced by either decreasing the amount of GFR that's taking place or increasing the reabsorption of sodium within the nephrons themselves. Counterbalancing that is the atrial natriuretic peptide, the ANP, coming from the right atria of the heart, that's going to inhibit the reabsorption of sodium so as to increase the amount of fluid being excreted at the nephron. And then we have hormones that are going to regulate calcium and the movement of calcium at the nephron. That's going to regulate blood calcium levels. So when we look at urine concentration, there's a couple of things that we're going to have to look at here, and most of this is going to be dependent upon Starling's law, as well as the hormonal regulation that's going to control the concentration of urine based off the concentration of solutes, where when we have low water balance within the body, we're going to have high concentrations within the plasma, which is going to lead to a concentrated urine due to high levels of ADH, high levels of aldosterone, and high levels of angiotensin II, while as we have low levels of ANP that's going to take place. Whereas when we have a high amount of water in the body, whereas we have low sodium or low salt contents within the body, we're going to flip this around. We're going to have high ANP, we're going to have low ADH, we're going to have low angiotensin II, and low aldosterone, which is going to lead to a increased level of water being permeable at the collecting ducts so that we are able to have as much water within the urine as possible. So let's take a look here at a couple of feedback loops that are going to take place. We'll start here looking at the feedback loop of ADH that's going to occur, in which we have our principal signals of high plasma osmolarity, as well as low peripheral pressure or low blood volume, which is going to stimulate the osmoreceptors and the baroreceptors to release ADH from the pituitary, which is going to head to the principal cells, which is going to increase the permeability for water, which is going to lead to the increased water reabsorption taking place. That increased water reabsorption that's going to occur within the nephron itself is going to lead to an increased concentration of urine, as well as a decreased volume of urine being produced. The low concentration of water in the urine, the low volume of water in the urine, is going to lead to the feedback loop here, the inhibition on the initial signals of low blood volume, low peripheral resistance, or high plasma osmolarity. So how is ADH going to go about doing this? How is ADH going to do this? ADH is going to do this by binding to the principal cells at the ADH receptors. These are going to lead to a G-linked cyclic AMP cascade. This G-linked cyclic AMP cascade is going to upregulate the aquaporin 2. Upregulation of aquaporin 2 is going to lead to a change of permeability for water and an inward movement of water from the nephron back into the capillaries. This is going to lead to the reabsorption of water taking place by diffusion of water across the lumen and then into the blood through osmotic conditions. And so how is this going to look in terms of overall movement? So if we look at it, what we're going to have our normal sodium chloride movements taking place within the principal cells with an impermeable membrane that's there. However, once we have ADH available to the cell, that's going to upregulate aquaporin 2, which is going to lead to the vesicylation of water within the aquaporin molecules themselves. That's going to lead to the translocation of water across the principal cells to the luminal side, from the luminal side to the capillary side, and then movement of water following the sodium and following the chloride into the plasma so that we have our reabsorption of water.
So let's take a look at the renin, angiotensin, and aldosterone pathway. So it all starts with low peripheral resistance and low blood volume, reducing the perfusion rate within the liver and the kidneys. This causes the production of renin and angiotensinogen. Renin and angiotensinogen produces angiotensin 1. At the same time, coming from the kidneys as well as from the lungs, we get a converting enzyme known as ACE. ACE is going to head out and convert angiotensin 1 into angiotensin 2. Angiotensin 2 is going to go everywhere. From the renals, it's going to induce increase of aldosterone, which heads to these nephrons to increase potassium excretion and increase of reabsorption of sodium so as to increase water reabsorption. At the same time, it's going to induce ADH release. Angiotensinogen and ADH is going to increase sodium reabsorption and water reabsorption from the kidneys. At the same time, angiotensinogen and ADH will induce vasoconstriction within the vasculature. The vasoconstriction within the vasculature is going to inhibit the total peripheral resistance, whereas by reabsorbing water, what we're able to do is change total blood volume by increasing it, because we're going to send water into blood volume as opposed to sending it into the urine. So what we're going to do is we're going to be producing a very small quantity of urine here that will be very concentrated because the amount of solutes stay the same. However, the volume of urine will decrease. So we looked at what happened in terms of ADH and aquaporin, but let's take a look at the potassium excretion rates and what happens when we start exhibiting aldosterone signaling. So under normal conditions, we will be exchanging potassium as well as sodium in terms of recollection so as to reabsorb water. This happens via a hydrogen antiporter and a hydrogen symporter that allows us to go ahead and buffer by the formation of bicarbonate as well as the ionic shuffle. This is under normal conditions. So we're constantly having this in which we're reabsorbing potassium. However, what ends up happening is that as we start to become dehydrated, we will start to reabsorb more sodium and start reabsorbing more water due to aquaporin and ADH signaling. But what we also start doing is we also start upregulating sodium-potassium pumps through the expression of aldosterone. The other thing that aldosterone will start to do is we'll start to express potassium channels, both on the luminal side as well as on the plasmal side of the nephron cells. And what the expression of aldosterone is going to do is it's going to increase the excretion of potassium via a sodium-potassium ATPase, as well as the upregulation of potassium channels. So what ends up happening is that we're going to start to see an elevated level of potassium within the urine that's being excreted, but a reduction in the amount of sodium that's being excreted. This is done so as to allow for the sodium ion, which has a larger water draw principle to it due to its large ionic sphere, to absorb additional water into the plasma and reduce the amount of water that stays within the nephron. All of this is taking place within the collecting tubules leading into the collecting ducts. Once we've hit the collecting ducts, particularly the latter segments of the collecting ducts, there's no more responsiveness to either ADH or aldosterone at the principal cells. So that's how we can go about making a very concentrated urine when we're needing to conserve water for the body. But that's not the only thing that's going to take place. We also have issues as relates to eliminating excess amounts of water. And this is all about the principles of diuretics. And diuretics are going to do a couple of things. They're either going to inhibit aldosterone, angiotensinogen, or ADH functionings, or they're going to somehow block the production of those hormones. The most potent diuretic that you have available to you is water. Water is going to directly inhibit ADH production from the hypothalamus and its excretion at the posterior pituitary. Other types of substances that we consume that will exhibit diuretic effects include things like alcohol, and to a lesser extent, alkaloids and xanthines. Now, this alkaloid and xanthine issue is how we go about getting the coffee having a diuretic effect or teas having a diuretic effect. However, the theobromine and caffeine and theophylline that we see in coffee, caffeine, and theobromine and theophylline in tea only exert their diuretic effect when they're in their crystalline form, not necessarily when they're in their aqueous form. However, other alkaloids, in particular ephedra alkaloids, what we usually refer to as stimulants, will have a diuretic effect. And so in these special considerations, I've given you a passage about the effect of dietary supplements and diet pills as a diuretic effect, and you may want to go about looking at that. Now, some of these loop diuretics we will give to, some of these diuretics, not necessarily the loop diuretics, but some of these diuretics we will go about giving to people who are hypertensive, in particular those who are hypovolemic hypertensives. The other thing we'll put these hypovolemic people on is what's referred to as a DASH diet or a low sodium diet, based on the concept that about 5% of the whole entire population is salt sensitive. The problem is that we can't really differentiate between a salt sensitive person and a salt insensitive person. And so most people who we put on diuretics, we will go about putting them on a low sodium diet as well. And this can have ramifications because people who are hypertensive, we tell them to go about being more active, which can become problematic because the more active the person is, the more salt deprived they become. And it can cause electrolyte imbalance issues, including hyponatremia, which is worse for you than being dehydrated.